Thank you so much. So now I want to invite all of the speakers to the table here for our Q&A. We will also be joined by Dr. Lee Beers, who will be participating in the Q&A remotely. Dr. Beers is the Medical Director for Municipal and Regional Affairs at the Child Health Advocacy Institute, a pediatrician at Children's Mental Health System, and co-director of the Early Child Innovation Network. Okay, so now is the Q&A. So the committee members can raise their hand if they have questions. Okay, so I think I saw Cynthia's go pretty fast.
Good morning. So these are, I find them great programs in spite of everything that is going on in the nation. You are trying to maintain services and effective interventions with people who are basically disregarded by most of the systems that we have in the United States. I had the privilege of once talking to George Albee. Does anybody remember George Albee? George used to say this, and I'm going to try to be short. George used to say this, we have babies going down the river, and we are in the middle of the river, and some of us decide to get a truck and start getting the babies out. And the questions he always posed, why don't we go to the top and figure out why are the babies coming down the river? So this is a question for any one of you. I would like these moms and these babies to have the life that I have had and that my kids have had. Not that they're being able to pay for diapers or that they're being able to stay in crumbling schools, but they're doing okay. And that's always been my problem with service-oriented solutions to structural solutions. So I'm being very blunt with you because I know that you're passionate and you care about the families, and so do I. But tell me, why do we have to stay where we are? Why can't we move the needle so their kids will go to our preschool and our kids will learn from their kids? I'm sorry, but I have to be blunt because we don't have time to waste more time and more great, studies that are going to stay there. And thank you for being patient with my impatience.
All right, I'll start, but I was going to defer to the policy person should she want to start. I do think that the tectonic plates of moving the structural determinants has to happen at the same time, but we shouldn't wait for them to move. So we've spent a lot of time thinking about what are the ladders out of those situations in terms of job trajectory. So just our hospital employs over 15,000 people. It has a terrible employment record in the local neighborhood. So at the same time that we're doing all these other obviously needed fixes, how do we start? And there is a consortium of large organizations in the city trying to work on workforce issues, but it can be as simple as if they can't get childcare and get to the physician, as you know, they're not going to show up to work on time. So a piece of the work I didn't present is working, for example, with HR and with the Cincinnati Child Poverty Collaborative. But I agree, those are the fundamental forces that mean we're always playing catch up. I don't know if you had other.
Well, I would just add from what we've observed in New York is that some of the larger agencies are starting to realize their own version of that story of up the river. So, healthcare is realizing that with healthcare costs rising and a sicker population emerging, we are not going to get out of our current predicament of frequent utilizers of healthcare services unless we move that prevention upstream. So I think part of that is it's going to have to start with individual agency enlightenment, agencies who are responsible for paying for services, thinking beyond payment of services to the other tools they can use, and then connecting at that very senior leadership level. I think someone stated earlier, it's really a governor or executive branch leadership decision to make some of those hard investments that move from services to structural and move from short-term to long-term.
Thank you. I think that one other piece that I always am conflicted about, to your point, is when we look at the literature on maternal depression, we see the same effect sizes around improving a family's income, $1,500 to $3,500 a year. And so that creates, I'll be honest as well, that creates a huge conflict in this. And so, in the data I presented, we've identified the reduction of maternal depressive symptoms as the mediator, as the mechanism there, and bringing about the outcomes around work and workforce. But I always wonder, we have data now on flex funds, so on programs and agencies and systems, child welfare system that gives families flex funds to secure a lease, to repair a car. And I really, that's a next step, is to put that into the model as well and really understand what's what's having the effect.
I think I hear Dr. Beers on the phone, right?
Yes, absolutely. Thank you so much for giving me the opportunity to join remotely. I appreciate it. And I agree with all of this, and thank you all so much for your presentations. I would also add, through some of our work, we've really tried to position ourselves as I don't know if this is a real term, but we've coined ourselves as translational advocates, similar to translational research, where in the spirit of co-creation, we're not just co-creating interventions, but we're trying to think about how do we co-create policy solutions through our work. And so positioning ourselves so that we can be learning from the things happening in the service delivery to actually bring those lessons up to the policymakers and help sort of transform real change that is not just change that I or, our city council thinks is a good idea, but change that is to come about together with the families who we're working together with.
Thank you. Jennifer, I think you had a question.
Sure. This, I think, is really targeted, towards all of you, but specifically Megan and Suzanne. One of my big questions is, what do policymakers need and want? We're here to try to provide that for them. When you're looking across the landscape, what's missing? I think I heard in Megan's talk perhaps really some methods and perhaps more rapid ways to measure the return on investment. I really liked your model there and kind of getting at that. But there's a lot of evidence out there, and Suzanne, it sounds like your group culled through most of it, if not all of it. What's missing? How can this committee contribute to the work that you're doing and accelerate your progress?
Yeah, I would say what we heard most often was a desire for outcome measures that aren't really available right now, but how would we particularly measure in the earliest 3 years parent-child attachment, or have better sense that children are on the right trajectory, but not just measures that can be applied through research, but can be practically applied, partially holding practitioners accountable, could be collected through state databases. So that's what we most often heard, was kind of a lack of measures that we could consistently use and do continuous improvement around beyond in a small community. I think what we realized in this process is when we were given a 3 to 4 month window to actually deliver something to policymakers, it was clear that there wasn't really an agenda ready to go for how Medicaid can be the most effective. I think part of that is it has to probably be state by state, because if you've seen one Medicaid program, you've seen one Medicaid program. But I think it revealed to me a gap in, what we know the research says and where there are interventions, but then really what exactly would a state agency do to act upon that research?
So if you all of a sudden have the will, then you don't have the action plan.
Yes.
I think our experience supports that as well. We found, cost per participant data was what we were often asked, and then templates around multi-generational data sharing. So were there examples of data sharing agreements that we could bring into a particular location? And templates, often this idea of co-construction was talked about, but really actionable steps on how you make co-construction systematic and can replicate it.
And I'll just briefly add, as I noted, we have seen some momentum around this, and this might be somewhat surprising, but in working with some of our policymakers here in DC around a specific birth to 3 bill, they really did actually want information on effective models and programs. And we may feel like that is readily and easily accessible, or we have a lot of that, but they were definitely looking for that. I mentioned our Attorney General, who has been very interested in the birth to 3, birth to 5 space, and they have been really interested in what are health education cross-sector models that maybe they wouldn't necessarily be implementing, but they could really, he and his office could really use their voice in terms of testimony and advocacy when budget period comes around, perhaps even lending support in that way. And I've also been in conversations with policymakers. Oftentimes, really frankly, they don't know what they don't know in terms of what's happening on the ground. And again, back to Dr. Beers's point about that translational advocacy piece, being able to bring what is working and what is not and have that, translating that into policy. I think, again, recognizing in DC, we're lucky to be in a fairly progressive system here, but they are looking for that information.
Dr. Beers, I can't see you, so if you want to jump in, rustle your paper, do something, so I'll know that you want to jump in. But right now,
absolutely, I will. No, you guys, this is going great. Thank you.
Okay, Albert, did you have a question?
So pretty much everything that you guys described requires some kind of change or shift in how professionals in these systems do their work, right? Whether it's early childhood providers or doctors or lawyers. Can you talk, I wonder if you have any reflections on what it's going to take to kind of help these professionals make those changes, whether, in a more systemic way, right? Like not just kind of intervention by intervention. So whether it's professional preparation, ongoing professional development, associations, what do you think we need to do to make that kind of shift?
I guess in our
People to do it.
No, to me the beauty of what seems to be working is people want to rewrite their roles. So we are in there as sort of catalysts and helping people see what the big outcome is and feel part of the change and have an active voice in the change. They will often contribute. Hey, why do I need to still keep doing this? And sort of leaning down what is not working versus focusing on what is working. We very much start with the early adopters, and then get the middle of the curve, and then the laggards can either join or by then the positions are rewritten. So for our medical assistants in the clinic or the teacher's aides or the reading specialists, it's not a force function. It's very much a draw function. And for the teachers to go from the annual, proficiency test to how am I making a difference every other week is a joyful experience. It's like an unburdening, and it's been very much pull. Now, we often get to now you got to move to a sustain phase, so those job descriptions do have to be rewritten, and that's often a fail where people can drift backwards. But it happens pretty naturally in this work. I don't know whether others have different experiences.
I would say.
This is Lee.
Go ahead, Lee.
Sorry, everyone. I would agree with that. I think we often approach things in a similar way to Rob. But I would also add, we try to sort of figure out where those those pain points are and those barriers for providers that are, I think we find a lot of providers actually are interested in thinking about doing things a different way, but the systematic barriers are great enough and they're so busy just doing their day-to-day stuff that it's hard for them to get past that. So we try to figure out where those pain points are and figure out then ways to relieve that. I think a lot about the work that we do with mental health screening and other types of screening, and sort of figuring out how do we lift some of the barriers and how do we do some of the behind the scenes stuff for practices and providers so that they can implement the changes more easily and that it's not quite as big of a lift for them, and that seems to make a big difference as well.
I was just going to add, for us being able to expose state leadership to on-the-ground collective impact efforts where people are demonstrating collaboration at a very local level has been very successful and encouraging them to participate in those efforts. I've also heard repeatedly, particularly from legislators, that taking the science that was in Neurons to neighborhoods and in particular showing brain scans to legislators has a very powerful effect on them. And I think it's working over time. I think we need to keep doing it and keep pushing that message out there.
Last thing I'll just quickly add, I do think the economic incentives are important, right? So when we reward a community health worker for 6 attempted contacts versus a successful outcome, it takes quite a bit to reorient that kind of incentive.
Just to alert people, we're going to just take a little bit of time from lunch, because we're not going to have these great speakers again, so we want to at least capture them while they're here. So we'll take a few more questions. Jim, I think you had a question, correct?
So thank you all very much. So all of you have done something to build coalitions. You've brought groups together as a fundamental part of the work. Yet the coalitions are very different. I mean, talking about New York DISRIP Coalition on Medicaid and Megan, the efforts to sort of get some support for providing moms' mental health, but working in community agencies to a degree. So they're very different kinds of coalitions. I'm wondering what kind of general principles there are that we should understand, that we should be really focusing on as we make some recommendations here. Do you have some thoughts about that, all of you?
I want her Medicaid coalition in my state of Ohio. That's okay.
I can start. I think this may sound simple, but starting with where you have momentum. I think with the Early Childhood Innovation Network, that really was born out of quite a few years of work and a coalition, public-private partnership that had come together around integrating mental health care into pediatric primary care. And there was a lot of really excellent and real tangible progress that was made out of that. And so people were really hungry and ready to go to the next level. It helps that we also had funders that wanted to help bring that to the next level. But we weren't starting from scratch. And so people were already, and again, not everyone who was at the table with ESON was at the table with the collaborative, but I think identifying and starting with where you might have made some momentum, made some progress can be really helpful.
I'll just build on that. We often call it a meritocracy. Rather than anybody who currently gets funding dollars relevant should get in the room to who's generating early results and how do you draw to those who are delivering.
I think just 3 things to add to that. One was, having a backbone agency, having some kind of infrastructure and support of a backbone agency was really critical for our efforts. A focus on non-traditional partners. So again, even though focusing on early childhood and health, thinking about the role of the private sector, the business community in that, really sparked innovation. And I think also, as we said before, this move to outcomes versus outputs was a really welcome change for a lot of members in the work. So, having a shared outcome versus just measuring, referrals or number of people served.
And I would just tack on, I completely agree with the backbone organization role. So having some group responsible for the coalition's process, ensuring that people feel people are not feel, people are listened to, that people have time inside the formal coalition or outside to air concerns, that people understand how decisions are going to be made within the coalition. It's really essential that there is a group or individual solely devoted to that piece and not pursuing their own agenda through the coalition.
Lee, is that you?
Nope, that was not me this time.
Okay, so I mean, oh, go ahead. So I mean, before I think I asked Michael to ask this question, I do want to ask the panel, to what extent does your initiative, your program, take into account or address structural racism? I asked that earlier, so I'm curious if at all, what you do about it and what it looks like.
I think being explicit about it has been, I liked, Sarah, your Racial Equity Council, I think is a great example of that. Having discussions, we're incredibly fortunate to have our local Healthy Start program that holds brown bags to actually talk about those topics. And so we support those efforts both financially and then, with staff. But I think also there's been larger systems change. Robert talked about human resources. And so, we've employed community mental health ambassadors through Yale and through other large systems that for many mothers that we employed, this was their first job with benefits. And we really had to change systems around orientation and talking about retirement accounts. So there's really, a systems level change around human resources that had to occur as well. I think for us, it's importantly talking with mothers and female caregivers about deconstructing it in many ways. What does that mean? Because a lot of times in some of those discussions, the issues of stress and trauma really emerge and are inextricably linked.
Michael, do you have a question?
I actually have a two-part question for each of you. The first is, how much does your program cost? And if you were to take it to scale to serve kind of all children, families in need in the nation, how much would that cost? And then the second part of the question, if you were to take your program to scale, it's probably not going to be financed by either federal or state government, given all the budget cuts at the state level and given the $1 trillion in tax breaks that would just given. What innovative funding options have you thought about to take your program to scale nationally?
I can start because my answer is fairly easy. The New York legislator appropriated $3 million for this year for implementation, which is 1/4 of the year, and $12 million for the second year. So it was very clear from the beginning there would not be big dollars devoted. We all look at it as a seed investment in some of these pilots. Some of the interventions are not high cost. They're really oriented around design, redesign initiatives between government agencies. So that's what the budget is. We really don't know what it would cost to take to scale, in part because we lack good cost information. We also don't know what's going to work on the ground yet. I can't foresee all, I don't know if all of these initiatives will be scaled or not. So that's really unknown. Yeah.
I still think of us in a startup phase. If you just looked at the averted extreme preterm births, we offset our initial couple years of cost in that sense. So I do think there will be cost savings through Medicaid, and we can and should be able to model that. We're modeling that now with Ohio Medicaid on our legal aid intervention. We're looking at scale up potentially across the state. But you asked sort of the ultimate question: what would it take to go national? And I think to me the end game is everybody endogenizes this kind of quality approach, which is you're accountable for outcomes and it's a part of doing your daily work. So for us, we're actively thinking, how do you work with the Cincinnati Public School Board of Education, the United Way Board, and so on. We have sort of a boards on board process by which they would foresee in 3 to 5 years these become internal costs to their program. It's a way of doing, the nuclear industry brings in quality and outcomes control within their own budgets.
Megan, you had.
I will let Dr. Beers, if she wants to, since she is our director.
I manage the budget. Yes, I can do that. So I would say this may sound like a bit much, but it's about a bit over $2 million a year for our programming. Now, keep in mind that's our infrastructure costs as well as our costs across all the pilots. Our infrastructure costs are going to run probably about $500,000 or $600,000 a year. That's, to be honest, lean, given all the different initiatives and different places we're in and sort of our commitment to the equity and co-creation side of things. And then sort of the follow-up question, how do we make this sustainable? There's sort of two pieces to that. The innovations with our partner sites, our hope actually is that our goal is to actually leverage our funding to ultimately make those innovations sustainable within the partner site through, and depending on the setting, through some combination of per pupil child funding or Medicaid reimbursement or other pieces. Again, as Sarah alluded to, we're in very, very preliminary discussions with one of our managed care organizations about bundled care payments. And so thinking about innovative things like that are an important piece. In terms of funding the infrastructure, I think, the stronger our infrastructure is, actually the more innovative pilots we can support. That, to this point, mostly comes through philanthropic funding because it is, as others have noted, it's sort of the backbone organization for the collective impact work. And there's not any great sustainable source of funding for that at this point, except for perhaps through city governments. But even that is not sustainable. So that's where we are with that.
So our average cost per participant is a little less than $2,000 per year. And I think in terms of changes that we would like on a systems level, I mean, many of our services are Medicaid reimbursable. We would need some Medicaid waivers to cover the cost of community mental health ambassadors. Prescriptions, perhaps, through Medicaid to support diapers when families leave the hospital, to support children's Tylenol, thermometers, basic needs, or consideration of diapers as durable medical goods. The flexibility, again, of the use of TANF funds and work participation dollars, whether it be in the TANF system, in some potential Medicaid systems that's being suggested, but work participation dollars and credit for participation in parenting programs and mental health programs.
So with that, I'm going to go ahead and close it up since we're sort of backing right into that lunchtime. But I want to make sure we take time to, again, thank our panelists and obviously the great questions from colleagues.